Good evening, everyone. Are my slides visible?
Yes, ma'am.
Right. Sorry, I'm just going to take this. Yeah. My presentation today. Yeah. So I'm going to be presenting about the case of a 66-year-old female who presented with 6 months history of skin rashes, which I will be describing later, 1 month history of proximal muscle weakness and pain, and 1 week history of difficulty in swallowing and nasal regurgitation of fluids. On examination, she was found to have an ovoid palatal patch and extensive skin involvement in the form of. So at this point of time, she had already received a lot of topical steroids. So these images. My presentation today. Yeah. So I'm going to be presenting about the case of a 66-year-old female who presented with 6 months history of skin rashes, which I will be describing later, 1 month history of proximal muscle weakness and pain, and 1 week history of difficulty in swallowing and nasal regurgitation of fluids. On examination, she was found to have an ovoid palatal patch and extensive skin involvement in the form of. So at this point of time, she had already received a lot of topical steroids. So these images are steroid modified. She had extensive hyperkeratotic and erythematous skin rashes, predominantly on the scalp, on the elbows, on the knees, in the ears, and she had typical features such as the V-neck. The Holstar sign, the Gotton's papule, and in addition to that, we also noticed that she had mechanic's hands and Hiker's feet as well. So coming to her motor examination, she had significant proximal muscle weakness with an MMT-8 score of 100 by 150, with significant neck flexor weakness and truncal weakness, and pharyngeal weakness as well, with a normal respiratory power. On investigation, she was found to have raised muscle enzymes. CPK was 4,800, and a myositis profile revealed strong positive TIF1 gamma. A malignancy screen revealed normal tumor markers were normal, and PET just showed the presence of active myositis without any evidence of underlying malignancy. So the treatment timeline. So July 22 to December 22 is before she came to us, where she predominantly only had skin manifestations. She was treated as psoriasis with topicals. December 22 is when she started developing muscle involvement. And at that point of time, at an outside physician's clinic, she was noted to have a weakness which correlated around 122 with high CPK levels. And she was started on full dose 1 mg per kg prednisolone along with methotrexate. February 22, 1 month, 4 weeks after this was started, is when she presented to us while she was on these medications. And despite these, she developed a significant worsening of her MMT score to 100 with development of pharyngeal weakness, neck flexor weakness, at which point in time we decided to give her IVIG 2 gram per kg over 5 days. A review 4 weeks later revealed that her scores had improved significantly. However, she still had a persistent weakness and she had persistent dysphagia, which was disturbing, as well as a persistently high CPK level. So at this point in time, considering her age, the requirement of a relatively high dose of prednisolone and fairly long duration of conventional synthetic DMARDs usage, we decided to give her injection rituximab 1 gram after counseling her and along with Septran prophylaxis. 1 month later, she had a very good response to rituximab with an MMT-8 score which had now improved to more than 125 and a complete normalization of CPK values. Unfortunately, in July, she contacted us from our hometown with complaints of headache and giddiness since the past 4 weeks. Her inflammatory markers have very significantly raised with a normal CPK. So we advised her to get imaged and follow up. And 2 weeks later, she was brought to our hospital in an E1, M1, V1 state. Her imaging showed multiple abscesses with ventricular burst, obstructive hydrocephalus, and meningitis. Her CSF showed pyogenic etiology. Immunoglobulins were significantly low with low total lymphocyte count. So she was treated with replacement IVIG, appropriate antibiotics, craniotomy, and an EVD. However, she finally succumbed to the infection. So our final diagnosis for this patient was a TIF1 gamma associated dermatomyositis without malignancy with rituximab-induced mortality due to infection. So coming to the discussion, so coming to the pathophysiology of TIF1 gamma. So as we all know very well, since its discovery in in association with inflammatory myositis in 2006. It's always been reported and studied extensively as a part of cancer-associated myositis. Even the hypothesized mechanism, which is basically due to its involvement due to its role as a part of the TRIM family in the transforming growth factor beta downregulation pathway, by which it regulates the various oncogenic genes that are associated with malignant pathogenesis. It can act as a tumor suppressor or a tumor promoter in some cancers. And due to its involvement in the TRIM family, TRIM family is known to be associated with interferon signaling. So this may be a link to the pathogenesis of myositis. So basically, any alteration in this TIF1 gamma antigen forms a neoantigen formation, which cross-reacts with the native TIF1. Now, while this pathophysiology is very well hypothesized in cancer-associated, it's not as well hypothesized in cases that are not associated with cancer, especially juvenile dermatomyositis, where it's 100% not associated, and in adult patients, around 50% of the adult patients, which shown to have which on follow-up also have shown to have no malignancy. So this calls into question the pathogenesis, some of which the mechanism is thought to be that it's a successful combustion of this tumor, which leads to the presence of myositis without any underlying malignancy that's detectable clinically. So some of the unique cutaneous features that are associated with TIF1 gamma dermatomyositis is basically its extensive skin involvement and its psoriasiform nature, which and a relatively milder muscle involvement. So these three considered, this leads to significant diagnostic delay, as was seen in our patient, which is also known, it's a known poor prognostic factor in these patients. Also noteworthy is that mechanic SANS, while it has been reported in 18 to 29% of patients with TIF1 gamma, Hiker's feat has been rarely described with TIF1 gamma. So even just as how the pathophysiology predominantly reflects on cancer-associated, even poor prognostic factors have been, even clinically as well as in studies, have been majority been described in the settings of cancer. So with malignancy being one of the biggest risk factors for poor outcome. However, you have other poor outcome measures as well, indicators as well, including older age at presentation, refractory muscle involvement, severe muscle involvement, delayed diagnosis, and severe skin involvement, all of which our patient had. So the predominant causes of mortality that have been noted in patients of TIF1 gamma-associated myositis are malignancy and systemic complications and infections. And the risk factors for malignancy, most of which were present even in our patient, including the older age group, dysphagia, V-neck rash, and overt palatal patch have been known to be associated with malignancy. So coming to the treatment of TIF1 gamma is fairly similar to TIF1 gamma that is not associated with malignancy. It's fairly similar to other antibodies. However, the important thing to mention here is that overall the usage of rituximab in this proportion of patients is quite less compared to others, probably because of its high association with malignancy, its lesser association with ILD, and its milder muscle involvement. So rituximab in general has definitely been shown to be quite a boon to patients with myositis, with many refractory patients benefiting from it. We have predictors of clinical improvement which have been known, in which TIF1 is supposed to respond, but not as well as JO1 and MI2. However, we have to keep in mind the predictors of the severe hypogammaglobulinemia infection, which includes poor prognostic poor prognosis of the underlying disease, which contributes a lot to the predictor of infection post-rituximab. So in conclusion, it's important to note that TIF1 gamma can have significant diagnosis delay because of its unique presentation. The classical poor prognostic factors that have been associated with malignancy have to be kept aside in other patients, and we have to consider these patients also as high disease activity, and cautious use of immunosuppression with a good balance, because those with poor prognostic factors also need a high level of immunosuppression, but they're also prone to have complications due to the same. So thank you. That's
Good,
all.
Kate.
Thank you.
Yeah, there are a couple of questions.
Was IgG done before giving rituximab?
Yes, sir. IgG was done prior. It was more than 1,000. It was normal.
Yeah. So now it's 536. That's not very low. It's not. I'm not sure would you be label this because of rituximab or with this IgG squatted. So, a lot of other things. And the dose of rituximab
Yes, sir.
was also not very high. It's only 1 gram.
Yes, sir. It was just 1 gram. Yes, sir. Even IgM
Yeah,
was low, and even I mean, that's why we concluded that it. I mean, obviously there are other factors that contributed to it, including the steroid usage, but we mainly mentioned that it's most likely because of rituximab.
yeah, I think this is a great case from the standpoint. Now, there was one question on the chat saying, could it be cancer? Are you sure it was infection?
So we also considered this in that actually her baseline, it wasn't very long before this, her death happened before our cancer screening, which showed absolutely nothing. And even at the time of her complication, her CT and MRI didn't particularly show anything suggestive of malignancy. The only thing that we could be dealing with is a hematological malignancy that was leading to these manifestations in the first place.
Yeah, a little unlikely, no?
Yes,
Considering that just about 2 months ago, a PET scan was done, and we relooked
yeah.
at the images also. We couldn't find those brain lesions. Although PET is not a great modality to look into the brain, but we couldn't find any such great lesions. Such rapid involvement, deterioration, and we couldn't find any cancer cells. Remember, whatever the mass was burst into the CSF space. So
Ventricle.
we did do the CSF analysis and couldn't find any abnormal cells. So we consider it more to be an infection. As rightly mentioned by all the faculty, she did have multiple factors predisposing her to this infection. Probably one of them is rituximab steroids, dysphagia, and multiple other issues. But everything happened very quickly. It didn't give much time for us to rescue her.
Very good question. Case. Actually, one more question I have is, so you're thinking it's rituximab, right? So, if immunoglobulins are normal, can rituximab still lead to infection?
Yes, sir. It can. Rituximab has been known to. I mean, there is also a T cell dysfunction and a late onset neutropenia that has been described in rituximab. So there is definitely a possibility of infection even with normal.
Very good, very good. Because immunoglobulin is not the only thing. In fact, what we see is even when the immunoglobulins are completely normal from rituximab, you can still lead to pretty lethal infections, like in your case. And there's also a lesson that not to use rituximab lightly. I feel like a lot of time in rheumatology, people are using rituximab very lightly without failing previous treatment, which I think can be a problem. But like in your case.
What was the
Um,
infection actually? Can you it was diagnosed which infection
Yeah.
was?
So her CSF analysis showed a pyogenic picture, basically 4,300 cells, predominantly neutrophils. But the CSF culture and multiplex analysis didn't show any organism. Her blood grew Burkholderia cepacia, but we're not sure of how contributory that was to the final picture.
Very good. I have there's one more question. I'm not sure. What immunosuppressant can we choose for concomitant cancer with patient if patient is already on chemo, like FOLFOX regimen?
Yes, sir. So steroids are our first option. IVIG can also be safely used in these patients. We have conventional synthetic DMARDs also, like azathioprine, and which can be used. Methotrexate has been associated sometimes with an immunomodulatory, which can affect cancer as well. So we keep that as a next option, not immediately.